And at that time, people used to always think that pediatric endocrinology is one branch, which is basically very, very rare, dealing with rare, complicated disorders, which require cumbersome evaluation and expensive treatment. This was a common thing. Everybody used to say, what will pediatric endocrinology do? Nothing much to be done this there. But when we started seeing patients, we were shocked by the way they were being managed. And this is one case with Dr. Rashmi and both of us managed. It was a very short child, diagnosed in 10 years with severe anemia, presented for the first time. And then at that point of time, there was a short stature and was given a blood transfusion, diagnosed as a case of celiac disease, but unfortunately had developed HIV because of the blood transfusion which happened in that scenario. So this was an unfortunate scenario, a case which should have been diagnosed at the right time and should have been managed in that perspective, or missed in that scenario. So we thought, what are the problem? Is it a problem of awareness, accessibility, or affordability? Now everybody says it is always a problem of cost. So people say cost is a major problem. But what is the truth is actually the elephant of the house is awareness. If you don't know when should you go, where should you go, how you should be managed, it is difficult. Once you go, direction is there, people will help you. People will help the patient will help themselves, but most important is awareness. So from there, we started our program, and 2012, we had the first PPEC, and a lot of people here, including all the seniors, Dr. Subrato, Dr. Rishi, everybody was part of that program. And since then, we have conducted huge number of programs across the region in the country. But unfortunately, how many physical programs one can do, that is a limit to that. So we started the advanced programs as well. So we moved forward from there to internet media, because now internet is available. So we started on YouTube around 7 years ago. And from there, we moved forward towards a structured program, both on-site as well as online. And now we have got the application and other things which are happening. We have e-learning program, which has got huge number of subscribers, and all of you would have accessed that. This would be something to go forward. But problem with YouTube is that you can see one video and then you forget about it. So if you want to have a systematic learning, we started off with this program of Medi classes 4 years ago, in which we now have a fellowship program and a diploma program. A lot of programs are there. A lot of people are part of that program as well. Now, we also run regular postgraduate fellow classes, and the publications and applications are there. Applications are going to make very easy day-to-day management in that regards. The often problem still remains is that the number of pediatric endocrinologists in the country may be around 100, and 100 may be an overrating, exaggeration. Cases are thousands. So what do we need to do? There needs to be a bridge between cases, pediatricians with special interest, and then more pediatric endocrinologists. This is what we are looking at. For that, now we are trying to come up with a solution, which hopefully will come up in the next 2 to 3 months, which will help you out using a personalized, intelligent EMR. So what it will do is that based upon your particular problem, so if a child has short stature, once you say short stature, specific questions will come with regards to history, examination. This will be there for all conditions. So precocious puberty, delayed puberty, DSD, whatever, 40 conditions we are developing these protocols. You just have to enter these data. Once you enter, you will ask specific questions in examination. So for a delayed puberty, it will ask anosmia. For precocious puberty, it will ask about headache. So different questions will come. Once you answer those questions, put basic data while you are examining the patient. This is looking very benign, simple. You're just putting. But what is, and you can simultaneously assess bone age there. So it looks very simple, you're doing that. But what is happening is that behind the scene, algorithms are running, which are then telling you this is the diagnosis. This is the investigations required. This is the likely treatment. And then you will get a lot of output. And you can then export it in the form of a proper, it will give you like a proper history has been taken. You will get results, interpretation. This is a work in progress. A lot of intelligent algorithms required. It will take time, but this is the way forward. So this will allow everywhere across the country to have a state-of-the-art, quality assured sort of a management, and then there could be connections with clinics as well. So this is something which we are working in that direction. Last 3 days, we had very intense program in the Regency Center for Diabetes Endocrinology and Research. Over 30 people from across the country had come, and it was a very good interaction with over 300 cases in which a lot of interactive discussion.
So this is a 2-year, 9-month-old boy who walked in to my OPD with a mustache. And this is how you pick up, the clinical eye, as they say, clinical acumen. You're sitting there, looking at the parent, the child walks in, and you see peripheral vision, he's got a mustache. And then detailed questioning, onset of pubic hair since 12 months of age, upper lip hair, prominent phallus, hoarse voice, history of penile erections. This is how you look. Look at this mustache. So what does it suggest to you as soon as you look at something like this? Maybe look at this acne. Look at that. This is a 2-year, 9-month-old. And the mother in Bengali said, "Ektu beshi." It's slightly more. So bilateral testes, enlarged testicular volume, 5 to 6 cc, stretched penile 9 centimeters, pubic hair stage 4, and height age 6 years, weight age 7 years. Weight age 6 years, height age, it is obscured there. Height age was 4.9 years, something like that. So, what is your first impression when you look at this? Precocious puberty. Yes, rapidly progressive precocious puberty, although the child was healthy and in many ways, and I'll use that word a little later on, indolent. The rest of the history was like this. Blood pressure was raised, 110/70. And also, there was another angle to this. Recurrent pain on the left side of abdomen for the last 4 months. Swelling, and on examination, swelling in the left hypochondrium and lumbar region of the abdomen, and oblongated 7 centimeters, 8 centimeters mass. So, as they say, the plot thickens. So, 2-year, 9-month-old boy, precocious puberty, abdominal mass, hypertension. What do you think of? Yes. So, one of the things is peripheral precocious puberty due to adrenal tumor. The other possibility, adrenal hyperplasia, 11 beta, although hypertension appears a little later, and an incidental abdominal mass. He looked so well, so healthy. Germ cell tumor and congenital adrenal hyperplasia leading to GIPP with secondary CPP. Why? Because in GIPP, your testicular size will be less than 4 cc. It was 5 to 6 cc. If you remove that, mass business, that's something you have to think of, or, testotoxicosis, where also you have severe virilization with small testes, testes about 5 to 6 cc's, and they don't respond to GnRH analogs. And look at this bone age. Bone age is 13. This is on the right side what a 3-year-old bone age should be from Grulich file. And in the middle is, again, Grulich file at 13. And this was the, the one, sorry, how do you go back? The one on the left panel was the X-ray of this child. So these are the numbers. FSH 0.1, LH suppressed, testosterone 4 nanogram per ml, which means 400 nanogram per deciliter. And DHES, we are talking about 700, etc., 5,000 DHES. And DHES is done in-house. So I got a call, sir, about 8 o'clock in the night. Child got admitted by 4 p.m. We had sent the blood. 8 p.m. I get a call. Sir, I get a DHES more than 1,000. Should I quantify it? Of course. I've never seen such a high DHES. So, gonadotrophin independent precocious puberty with likely adrenal pathology. Serum aldosterone was raised, cortisol was normal, ACTH was suppressed, 17-OHP was normal, serum electrolytes were normal. So, CH is ruled out. Tumor markers, beta HCG, serum AFP. So, germ cell tumors were ruled out. The blood pressure was raised We did give it a lot of attention. This was a 2-year, 9-month by 100 by 70, 110 by 70. So we started Libicolol, keep raising the dose. And then we looked at end organ dysfunction, but 2D echo was normal, renal function was normal, fundoscopy was normal. And the response to Libicolol was somewhat muted. But because we got the ando level, we started spironolactone. Blood pressure started improving. But this is what we did on the night of the patient getting admitted. We got a CCT done. No, the next morning, early morning. And that's what it shows this, paravertebral region, a huge mass of necrosis and calcification. Now look at this. This was the section. And look, I mean, the pointer is not working, but you see how this is the इसी से होता है अच्छा ठीक you see this anyway, just see the left adrenal is that mass out there and how it is distinct from the abdominal mass. So the CT showed there was a mass which was distinct from the tumor. So then we kept thinking maybe it is germ cell or it is rest, adrenal rest in the retroperitoneum. And so all these thoughts were there. But we did a biopsy. The synaptophysin was positive. So clearly, ACTH was around. And this, we did the calretinine, which is an immunohistochemistry marker in which 95%, if it is positive, 95% sensitive for adrenal cortex. And chromogranin A is, if it's positive, it is significant for adrenal medulla. And it's very important to make the distinction, pre-op, in case there are some medullary, aspects when you're really handling it and doing this and that, we might have a hypertensive crisis. But when we proved that this is entirely an adrenal cortical origin, we went ahead and did the surgery. It was huge, 8 centimeters plus, and a tip of the adrenal. The adrenal was actually attached to the rest, so it was rising from the adrenal. And this is how it looks. It really looks gross. Now, this is the beauty, this slide. Normal adrenal tissue and how it goes on to the tumor cells. And so this indeed was an adrenal tumor. Now, this is a magnified view. And I'm not going to go into all the criteria, but just to share with you the Weiss criteria, which decides whether it is a carcinoma or an adenoma. Now, one thing to remember, whenever we read pediatric endocrinology books or listen to lectures, any small child with adrenal tumor is cancer unless proved otherwise. It's adrenal carcinoma in this young age group. But this baby, this child had an intact, they had an intact cortex, and there was no other spreads anywhere. CT chest was normal. And so this is what happened post-op. As soon as the thing was resected in entirety, the DHEAS fell to 5.4, testosterone went down, ACTH came up. Now, there was a cortisol went down. So, there was some, there was some suppression of the, fasciculator, because it was the reticularis which was working overtime and producing the huge amounts of DHEA, which was getting converted to testosterone. So we did the ACTH stimulation test, and we found that the reserves were not good enough. It was less than the stimulated levels were less than 20. So we, so this is the final diagnosis: adrenal adenoma leading to gonadotropin, GIPP, and hypertension, excision of tumor and left adrenalectomy, and post-operative cortisol deficiency. So what are the conundrums? 8+ centimeter adrenal tumor with intact capsule, with benign cytology and Weiss criteria. Is that possible? Literature differs. Anything beyond 4 centimeters is malignancy unless proven otherwise. So what are we going to do? They are going to publish this because it's the largest tumor ever known to man or beast in a 2-year, 9-month-old. What was the cause of the hypertension? I mean, we're talking on one hand, the pure gonadotropin, pure, gonadotropin independent, precocious puberty. And then where does the hypertension come from? And actually, the blood pressure levels came down before discharge. And then when we saw for follow-up and we reduce the antihypertensive, the blood pressures come up again. So it is another conundrum we haven't solved, but we will get to it when he comes back again. So why were the aldo levels elevated, which fell after the tumor resections? How should he be monitored clinically and biochemically? So our plan right now is going by conventional wisdom. Don't outright declare he's the first avatar of a 9-centimeter normal, adenomatous adrenal, but follow up every 3 months, do a USG and a DHEAS and see if that starts going up, then we will think of doing a PET scan or other things. And what will be his final height? He is 104 centimeters, bone age of 13. I think he's going to be pocket Hercules. That's why the name. So thank you. Thank you for your patience.
I have a doubt, sir. So this, So shouldn't the biopsy be repeated again, sir, at some other center, sir? So because there are certain odd points which are against, as you told, size is one of the factors.
No, Baki, if you see the WISE criteria, I didn't want, in interest of time, go into all the details. This is the WISE criteria, in which 3 or more have to be positive for adrenal cortical carcinoma. And here, none of them except necrosis was positive.
Yeah.
So the pathologist actually thumped on the table and said, no.
I think that's a very, very interesting case, but I would be very wary because it doesn't look like a single monoclonal tumor. It looks like it is also producing some aldosterone, it is also producing some cortisol. And that is why his bone age is so much and his height is also not that much. It basically means that cortisol is pulling him down and androgen and estrogen is pushing him up.
But his cortisol was only 7.
But why did he develop post? So there was some subclinical hypercortisolism.
There must have been because his ACTH was suppressed.
Yes.
So once we removed it,
it went up. So there is probably this at least 2 lines you said aldosterone was also on the higher side. So it doesn't look like a monoclonal one. It looks like biclonal or polyclonal, which means it is not a benign one. It may be more towards malignancy. So I will vary. I'm not saying that we have to do anything.
You're absolutely right. That's why I put those conundrums at the end. This is truly the conundrum that on one hand, we have this, and also this bone age, it has gone. So even though the parents said, this has been going on from 6 months of age or something like that, which is absolutely in the carcinoma, category. But the high levels of DHEAS has pushed this bone age from a 3-year-old to 13 years, 10 years in 2 years' time. And the point is, with so much aggression in the growth of the tumor, by now you would have expected the capsule to have ruptured, mets. So
very, very, very interesting. And the big message probably is that if you have short, like his bone age is advanced and he's not that tall. He's only 4 years as far as height age is concerned. So there's something cortisol is also doing.
That is exactly the point, because when we have a genuine patient with, adrenal carcinoma, it was beautiful. It was completely hairy as a girl, and beard, mustache, all that, and was Cushingoid. When we removed the tumor, which was carcinoma, everything fell off, and there the bone age was a 10-month-old with a bone age of 9 months, because it had balanced beautifully. But the cortisol values were not that high.
So I think, but that's a very, very wonderful case. I think round of applause for Dada for these 2 wonderful cases. And I think that will bring us to the end of the session. I now request Dr. Neha to kindly.
Sir, I have one question.
Yeah.
I would like to have your comment on where these patients were unilateral creation.
Yeah.
carcinoma of adrenal adenoma is there.
Yeah.
So other adrenal is suppressed or down-regulating the receptor. How we should proceed to how it comes up?
So definitely in the initial phase, you have to cover with perioperative steroid cover, stress dosage, start with a physiological replacement, and then gradually try to build up. Because there will be suppression. If it's a unilateral adenoma, 100%, if it's a cortisol producing adenoma, you will suppress the other axis. So you will have to give low dose. So initially stress, complete 100 milligram per meter square, and then try to build up and then gradually go from it.
Which is what we did.
Yeah.
This baby was, this child was actually sent home. That's why we did the ACTH stimulation test, because we were worried about that. And we started the replacement, and with the proviso that if there is sickness, you triple the dose, because as you rightly said, the other gland is suppressed. And once we remove this, and Dr. Bajpai made that point, the one gland is producing more cortisol, ACTH is suppressed, so obviously the other gland is also suppressed. But having said that, that was the only contention, is the cortisol levels were not as high as we would have expected. But having said that, ultimately it is a biochemical test. And what was beautiful is when we repeated it, it fell. So I agree, there is some aspect of overproduction. So maybe that's why.
Blood pressure is not high.
Yes.
Yes, and the blood pressure is high, but the
Endo is also high.
aldo is also high.
So there's a polychloride.
But just to clarify the point which Dr. Anurag has said, that if there was some, there was some confrontation between testosterone and cortisol as far as the bone age is advanced so much, it's like the DHEAS, the cortisol को 1 gram दवा दिया. In the sense that producing some bone age delay has been completely.
But height has not increased that. Height has not increased that. So you should have grown height.
But bone age will come in knowledge.
Thank you, sir, for such a nice case. Just two issues still we have to, because this is really a conundrum case, and I really appreciate that small Hercules. That testicular volume, 6 ml, still we have to.
Answer.
Sir.
You see, what happens is that these children, when they bone age goes beyond 11 or 12, they go into secondary CPP.
Yes.
And that's when the testes can increase in size. But here we have no way of knowing, because the DHEAS has trashed the FSH.
Yes.
So I'm giving it time now to see if the FSH start drifting up, and maybe 3 months down the line, I do a GnRH stimulation test, because that might again continue to increase the bone age and make the child even shorter.
And one more make note for trainees that if this type of case is there, and before even biopsy, we can ask some more details about radiologists, that what is the strength of HOE, that Hounsfield unit. So if Hounsfield unit is pretty much high, it 3 digits, probability of say malignancy is very high, and that child should be definitely done for biopsy. So that is my additional point.
So the classical differentiating feature on radiology are 5 more than 4 centimeters, heterogeneous, enhancement which is retained, and you have a Hounsfield unit more than +20. So these will be benign versus malignant. So more than 4 centimeters, adults they say it is malignant.
Yes.
So we don't stop thinking about that.
And then adult endocrinology will say, I don't believe. You wait for this 6 months until you publish this case as the first case of giant adenoma. But one other point, this is again for the trainees. Normally in pediatrics, you do 5 millimeter cuts for anything else. But in adrenal, remember, you do 3 millimeter cuts. Yes. And ultra thin slices, 1 millimeter cuts, which is also, some people like HRC, that's nothing but 1 millimeter. So here, because we did not do 5 millimeter cuts, the adrenal and the mass were conjoined, it didn't appear. In fact, the picture showed they were separate because of 5 millimeter cuts.